Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi washabbihi ajma'in. Assalamualaikum dan selamat pagi. Selamat datang ke majlis CME Mimbar kita pada hari ini. Yang berbahagia Dr. Bukti Nurbaya binti Muhammad Ismail, Kepala Pengarah Perubatan 1, Dr. Ibu Dr. Nohana binti Muhammad Fasih, Kepala Pengarah Perubatan 3, Ketua-ketua jabatan, ketua-ketua ini, pakar-pakar pegawai yang saya hormati. InsyaAllah pada pagi yang penuh keberkatan ini, kita akan dengan sesi CME seperti biasa. Dan pagi ini kita sangat bersyukur kerana di atas pentas Muhammad Hakim bin Zainiyat, seorang pakar perubatan rehabilitasi yang akan berkongsi satu tajuk yang saya tak banyak nak sebut ni pasal kawan-kawan kami bertajuk Nyetok Karung nak buat Gano. Boleh ikut Okey, tanpa buang masa saya mempersilakan Dr. Muhammad Hakim untuk menyampaikan ceramah dia dengan segala hormatnya.
Assalamualaikum. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih banyak-banyak Tuan. Terima kasih Hafiz. Boleh macam mana? Kalau ada video, nanti dia auto-play sendiri sampai dekat sepatutnya. Okey, Assalamualaikum warahmatullahi wabarakatuh. Saya pun bukan orang Kelantan juga. Saya pun tak reti macam mana nak sebut. Tapi itulah, well, a little bit of introduction about myself. Assalamualaikum semua. Saya banyak muka yang saya tak kenal lagi. Saya pun baru kenal timbalan pengarah kita. I just joined SJPZ ni on the 31st of January. Saya baru pas saya punya master program. dekat UM lah. So before that I was serving Sabah sebab saya orang Sabah sebenarnya. Okay, why I choose this Nyetok Karung? Because we currently have a difficult patient, spasm, very difficult spasm. So I think maybe I could share little bit of here and there pasal kita orang punya management about this patient. It's a spinal cord injury patient, quite young, 34 years old, but very obese, morbid obesity, female, 175 cm with a weight of 150 kilos. Penuh katil. Cuma itulah, I find something interesting about Kelantan, okay? Because all the while, when I serve, even in Sabah, spasm is a jargon, medical jargon. I ask patient, ada spasm ke pakcik? Pakcik akan, they don't have a proper word for it. Tarik-tarik kini, but tarik-tarik could be fitting as well, or clonic jerks, you know. So, bila sampai Kelantan, I learned this new tata bahasa ni lah, Nyetok. So apparently Kelantan they have a proper word for it. Spasms equal to Nyetok. So Nyetok Karung, that's why I put it here. And bila Google tu, baru tahu yang the layman term for it is simple biawak or apa tarik mengkarung. I don't know why. Why biawak, why mengkarung, I'm not sure. So I think it's just it's a good thing like that we know the layman term for spasm because it's a medical jargon. Okay, but my topic of talk today, I would like to focus on something related to upper motor neuron punya pathology, because when you talk about spasm is something very wide, you know. Dia boleh jadi something from as a result of a local muscle trauma, you know. So discussion will be very broad, and we don't have a focus sangat kat situ. So but bila you talk about spasm, upper motor neuron, you cannot like take away the spasm part from spasticity. The discussion would be spasticity, spasm, and other overactive overactive motor component of the upper motor neuron syndrome. So we shall start. I try to make it short and senang nak faham, inshallah. So let's look at spasticity and spasm, because usually people will just lump these things together, spasticity, and everything is just spasticity, spasm, hypertonic, any chronic movement that comes with it, everything is just spasticity. But when you look at the definition, spasticity is actually, it's a velocity-dependent increase in muscle tone that is caused by increase in excitability of the muscle stretch reflex. So it emphasizes that velocity dependent and stretch reflex. That's why when we check patient for spasticity, we don't do pakcik gini, or spastic ni, or rigid ni. No. Spasticity, let's say you're checking for the bicep, you have to stretch the bicep. We do it with velocity. Tarik gitu. So spasticity is present when you notice a catch. Okay, tarik, catch, then there will be increased tone throughout the range of motion. Or if the spasticity is very severe, barang tarik sikit, that's already a catch, and it goes all the way up to the end of range of motion if there is no contraction component. But spasm, on the other hand, is maybe they can just say it's just involuntary muscle contraction. It could be mild, it could be severe, it could be very painful, it could be very disturbing. It comes in a varying degree of severity. So for the etiology, spasticity usually memang akan related to disorder of the upper motor neuron. It's a central cause, while spasm could be a central cause as well, part of the central cause, but could be peripheral. It could be a muscle sprain or muscle injury problems. So the symptoms, as I said just now, it could vary. Typical of upper motor neuron lesion, spasticity will have stiffness, hypertonicity, a kind of hyperreflexia as well. But spasm could vary from jerks, twitches, cramps, you know. Okay. So there are lists of causes here. It's not like they are independent over one another, but yeah, ada banyak sebenarnya. Okay. But what we can say is spasticity is a feature of upper motor neuron lesion, and spasm could be part of it. So a bit of pathophysiology, just a bit of refreshment. I will not go in detail into this, but I pun tak ada tahu sangat pasal pathophysiology. So, but there are few theories here. When you read the textbooks or when you read the articles, journals and all, theory is just theories. You akan cakap banyak benda, loss of descending facilitatory, inhibitory influences, ada some mismatch here and there, this one is firing, that one is not inhibiting, you know, those are the theories. Memang macam tu. But at the end of the day, dia akan cakap, actually it's just theory and dia tak ada satu yang like a very concrete pathophysiology behind it. Cuma, this position here, Xian et al., they highlight something a bit interesting, where this muscle of overactivity in upper motor neuron syndromes, they could actually divide it into three distinct categories based on their underlying etiologies. And what are they? So these are the three distinct categories might lead to this, symptoms that we observe in upper motor neuron patients. Okay, first is the disorder of spinal reflexes. This involves stretch, nociceptive, and cutaneous disorder of reflexes. And the second one would be supraspinal efferent drives that are not totally dependent on afferent feedback from the periphery. And the third one is disorder of voluntary muscle movement. So let's go through this one by one. Okay, so the disorder of spinal reflex. Okay, there's an increase in stretch reflex, which include the tone itself and the facet contraction. A simple example for this is spasticity. You know, there's an increase in deep tendon reflex. And another example for this is a clonus. Okay, so it's a flexor reflex afferent which resulting from obtuse stimulant. Babinski pun sama, is something that results from cutaneous reflexes. So the second one is a supraspinal efferent drive that are not totally dependent on afferent feedback from the periphery. So this theory, it proposed the physiology behind why stroke patients have this flexor pattern, flexor synergy pattern. Okay, so it was first described by this Danny Brown when they observed a cat with spinal injury, where the cat held its limb in flexor position. So they dig further, they do a dorsal root transaction, it remains in that position. So they come with this theory, there must be some supraspinal efferent drive that is not actually dependent on the afferent feedback. So in stroke patient, you can see this flexor synergy pattern. They're accentuated as the patient attempt to sit up, or attempt to walk, or attempt to do something. Okay, so and it is somewhat proportional to the degree of exertion. Yes. Okay, sorry for the schedule. Okay, so I have a video here. Good job. Resume slideshow. Okay, take a look at this patient. This is a very young gentleman with stroke and recovering. He's a very fit guy. He belongs to the army. So just look at his gait pattern. I just want to show you two things here. One is the flexor synergy, how it changes the angulation of the punya upper limb too. Initially, dia start flexing. When he start moving, dia akan flexing more. And try to observe dia punya left toe. There will be a clawing. There will be a visible clawing there. See the hands start moving up, goes up, goes up. Yes. Kaki will start clawing. Every time he moves. Okay. So this is the second theory. So the third one, it is related to disorder of voluntary muscle movement. So this is referring to disturbance in the reciprocal inhibition. For example, in a normal movement, when we attempt to extend our elbow, sepatutnya our bicep to relax and our tricep contracts. The same goes to our plantar flexors. Bila kita attempt for dorsiflexion, they should relax. But in this case, you can see this is definitely from a different patient, but they have a similar problem. You can see at the toes, they're becoming clogged macam tu. They're a problem with reciprocal inhibition. So for some reason, when he tried to clear the ground, he should dorsiflex, but somehow dia punya flexor digitorum tu take over. Okay, so these are the kind of patients yang we can do something about the spasm. You can either use medication, oral medication for the upper limb just now, or we can use local treatment interventions. Like this one, it's a very focal. You can inject the muscle, Botox or nerve blocker. So we will discuss that in management. So now that we have seen a little bit of the physiology and what are the symptoms that our patients could present with. So how are we going to assess this spasm or spasticity? So there are a few outcome measures. I mean, there are a few scales to assess spasm spasticity, but normally what we use are these two: pen spasm frequency scale and modified Ashworth scale for spasticity. So pen spasm is something that is reported by patient. They will say, kita akan do the one round, tanya patient, ada nyetok lagi tak? So dia akan bagilah whether it's no spasm, you grade it as 0, or mild spasm induced by stimulation. For example, every time they attempt move the limb, then they are kind of spasm too. Or grade 2 is an infrequent full spasm, but it occurs less than once every hour. So spasm yang number grade 3 ni, did occur more than once per hour, and spasm grade 4 is the worst one. And obviously, why we would want to quantify this is satu, for the sake of documentation. Satu lagi is for the sake of relaying the information to our therapists and among doctors and nurses, because this is sort of like a universal language for us. And another one is you can somewhat estimate to what extent the spasm can affect your patient's mobility or participation in therapy. Okay, so modified Ashworth scale, the other 0 sampai 4, depending on how severe is the catch to the muscle just now. So if you have identified this, and let's say you have decided your patient have a certain amount of spasm or spasticity, and you want to initiate treatment, so you cannot just simply initiate treatment based on whatever resources that is available to you. So you have to set a goal for them. So goal setting, usually we divide it into 2. The first one would be management of the passive function, things like pain, positioning, hygiene, and the other one would be things that are related to active functional activities, something yang akan insyaAllah akan meningkatkan lagi patient tu punya mobility or functional capacity. So when we want to establish this goal setting for every patient, obviously every patient they have different problems. The magnitude, the severity of the problems are different from patient to patient. So it has to be tailored for each patient. So you have to consider feedback from multiple sources. Our therapists, we talk to our therapists, how is this patient participating? Is she or he okay? Or is the spasm really disturbing? Or is the spasticity is the one that disturbing her? And then you have to ask the patient as well. Tanya patient sendiri, whether the pain is bearable, whether the sleep is disturbed because of the symptoms, or there's a difficulty in maintaining body hygiene and mobility. So goal setting is something that you have to include everyone, nurses, doctors, patients, therapists. So we check. So we come to management. We can divide it into four groups: non-pharmacological, pharmacological, and we have minimally invasive procedures. The last one would be surgical intervention. So for non-pharmacological intervention, non-pharmacological therapy, there are a lot actually that can be done by our therapists. For example, positioning, it could improve spasm. For example, here, nurses let's say nurses handling a patient, they have to be a bit vigilant with the patient's positioning. For example, try to avoid leg scissoring, try to avoid windswept position, and look for noxious stimulation, because this often can precipitate for worsening of spasm. For example, infected pressure ulcer, or maybe patient have ingrown toenails, kink catheter, or patient have urolithiasis, or for some reason patient have UTI, and this is very apparent, especially in patient with spinal cord injury. So memang kita akan nampak spasms there, spasticity there will get worse if this noxious stimulation is not removed. Okay. So for local treatment benefit, you have stretching exercise, you have casting. Sometimes we can prescribe tone reducing orthosis, and to a certain extent, I think kinesiology tape will help. But this one maybe the sports are more well versed about it. Okay. And we have physical modalities, heat therapy. It could be deep heat or superficial heat, where you can deliver by ultrasound, paraffin bath, fluidotherapy, whirlpools, most popular. And you have electrical stimulation, usually meant for pain control. You have TENS, you have interferential therapy. In some centers, they do implement functional electrical stimulation, where they apply the electrode in a reciprocal pattern to imitate the movement of a normal muscle physiology. And last but not least is this manual therapy. Walaupun bunyi di manual therapy is just massage, but sometimes massage do relieve a lot of the symptoms. Okay. So before we start pharmacological therapy, there are a lot of considerations actually. For example, first you have to think of what is the etiology behind it, at what stage of the illness this patient is, what is the functional prognosis of the patient, does the patient have a support system, how's the cognitive status, whether they had a concurrent medical problem, and not forgetting financial limitation. And another one I forget to put here is how the spasm, the spasticity is distributed, whether it's a widespread spasticity like hemiplegic or paraplegic kind macam tu, or is it just a focal spasm, macam the one that involving the palmar aspect of the foot surgery. So all this need to be considered. Okay. So generally, medication for spasticity spasm, dia sama je, lebih kurang je. We use one. We use the medication to take out both actually. So you have these groups. You have baclofen, you have or benzodiazepines, dantrolene, clonidine, and tizanidine. So these three things here. Baclofen is GABA B, benzodiazepine is GABA A, and tizanidine is alpha agonist. These three, they are centrally acting. They are modulating the neurotransmitter. But dantrolene is different. It acts at the muscle. It prevents the release of calcium from the sarcoplasmic reticulum. So what happened is the contraction will not be as strong. So maybe you get the benefit of a reduced tone, but it might cause weakness of the muscle as well. Okay, so there's no one medication yang superior over the other. So we will look through one by one. Okay, so inilah tempatnya, this is just nak mudah bagi nampak is a pictograph representation. Baclofen, benzodiazepine group, and tizanidine, they will work at the central medication, and dantrolene will work at the level of the muscle. So this is just basically quite dry, this part, like baclofen, the usage in SCI and spinal cord injury and multiple sclerosis. Studies have shown improvement in spasticity and flexor spasm in both of these groups. So, but in ABI, there are limited evidence so far, but we do see physicians use baclofen for spasticity in ABI-related injury. ABI means acquired brain injury. Okay, so for the similar things goes to patient with the cerebral palsy, there will be improvement in most of the studies. Benzodiazepine, so usage in SCI it shows great benefit. Okay. In MS, multiple sclerosis, it shows comparable benefit as a similar efficacy as baclofen. Just that benzodiazepine group, when it is considered to be used in MBI, the problem is it's a potential cognitive side effect because a patient with MBI usually they will have a cognitive problem. So you want them to recover from the cognitive problem. So you don't want to suppress that. Okay, it might potentially compromise motor recovery as well. So for CP, the study shows that there will be benefit in terms of improving LDL, activity of daily living, which translates into improvement in functional capacity and reducing care burden. Okay, so tizanidine, the alpha-2 agonist, there are two types available, tizanidine and clonidine. By the way, baclofen and benzodiazepine group is the one that we usually use here is clonazepam. These two are readily available. But this alpha-2 agonist, tizanidine, clonidine, it's not readily available. They can special order. Tizanidine, I've never had the experience to prescribe tizanidine before, even in UM. Okay. So for tizanidine, the usage in XCI could be considered as effective in terms of reducing spasm and spasticity. In multiple sclerosis, it is as effective as baclofen. There's a mixed finding in a patient with acute acquired brain injury and has very limited evidence in cerebral palsy. Tizanidine, based on my reading, their side effect too is more profound if you compare to baclofen and benzodiazepines. So dantrolene is the one that acts at the periphery, at the muscle itself. So for SCI population, the study shows that dantrolene is more effective than diazepam in controlling spasticity. But the problem is because it acts directly on the muscle, it also associated with greater weakness. Okay. So there's some studies shows that there's improvement in range of motion, but it is not directly translated into improvement in function, and it has limited evidence for use in multiple sclerosis. For MBI patient with acquired brain injury, there's one study shows there's improvement in terms of range of motion, intended reflex, and upper extremity functions for patients who are treated with dantrolene. Dantrolene is not something that is readily available, something that needs special order if I'm mistaken. Okay, there are also other drugs to treat local muscle spasm, but I think the one that we are familiar with is just Malonal. The rest of the things, basically all this is things in the textbook or things in the internet when you Google. So there are other medications as well that could have spasmolytic or antispasmodic kind of properties. For example, like piracetam. Some studies shows that piracetam could improve passive joint range, hand function, and ambulation. Cannabinoids are still under studies. Gabapentinoids, gabapentin, pregabalin smoking, even Keppra, they might have some benefit or mungkin membantu juga. So we have minimally invasive procedures. This is more reserved towards focal spasm. For example, just now if you remember, I showed you the flexor spasm of the foot. So usually those kind of patients, rather than giving systemic medication, we will intervene, do intervention. So what are available treatment for this? We have nerve blocks, we have motor point blocks, and we have chemical denervation. Nerve block, motor point blocks ni lebih kurang. Basically, you are targeting the nerve or the course of the nerve, and you give something to block the transmission of the nerve. For example, what we do, and what we usually do is kita trace, kita bagi dia local anesthetic. We can give just lignocaine or bupivacaine. Lignocaine obviously is a fast-acting, and bupivacaine, the effect will last longer. So, contoh nerve block, let's say the patient has quite a severe flexor-CDG pattern, yang bila dia jalan dia akan naik lagi and impact his balance. There's a role for doing either nerve block or you can do Botox to the patient. But the thing about Botox is Botox does not work immediately. Nerve block work immediately. So we tried to do case series last time. We tried to do multiple sessions of multiple patients doing nerve block. And these patients are chronic patients who somehow become not responding to our Botox treatment anymore. So it's quite simple actually. For example, you want to block the musculocutaneous nerve. It's just here, put ultrasound here, there's a big nerve there. Use your needle, guide it with ultrasound, deliver the medication. It's not a problem. You just need to avoid vessels. Usually benda tu is quite easy to do. Cuma you need some training and you need a good ultrasound. For now, big nerve boleh with our ultrasound available sekarang. Nerves that are big nerve boleh, tak ada masalah. But if you want to do motor point, because motor point you have to trace down the nerve up to the muscle. It's a bit difficult. If your ultrasound is not as high resolution, it's a bit difficult. Susah nak cari. And chemical denervation is where you try to denature the nerve, merosakkan nerve to some chemicals, and the chemical that we usually use is phenol and ethanol. So it will give somewhat similar effect, macam nerve block and motor point block, but it will be longer lasting. Sebab you denature the nerve tu rosak sikit. Eventually dia akan recover lah, but it takes more time. Kalau kita tengok apa nama dia ni, journals or case reports ke apa, they will say sometimes they last up to 6 to 9 months, and some reported cases up to 12 months. Okay, but the problem with chemical denervation, if it's done wrongly, if you terkena dengan the nerve that carries the sensation, patient might end up having neuropathic pain pula. You want to settle a problem, you induce another problem, which is a neuropathic pain. Okay, so and then Botox lah. Botox obviously inject directly to the muscles. We have two choice yang kebiasaannya kita pakai kat sini, which is Dysport and Botox, Botulinum and Abobotulinum. Incobotulinum ni macam Xeomin ni is not available in our market as far as I know. Then you have Myoblock, and there are a few other options coming from Korea and China as well. That's something yang I tak nak pakai kat sini, yang tak nak pakai. Usually kita biasa pakai Botox and Dysport saja, which are type A toxins lah. Botox they have 7 or 8 types, 7 types macam tu banyak types, but the one that commercially used is type A and type B lah. So for surgical related intervention, we have intrathecal medication. Baclofen can be delivered intrathecally, morphine and clonidine as well. But we have very little experience on this. I think in Malaysia, maybe in HRC, ada 1-2 patient je yang pakai intrathecal baclofen, and this is reserved for patients with severe spasticity juga lah. And then you have to very carefully select your patient for this, because intrathecal baclofen is a device yang memerlukan maintenance. Patient has to be able to, they don't have issue with logistic, they don't have issue with mobility, they don't have issue with cognition, semua ni, and they will be able to maintain the devices. Then probably those patients are suitable for baclofen. Dorsal root transotomy pun jarang buat. We have so far during my years in UM, we never referred one. But I heard Prof. Jeffrey Malin, neurosurgery in USM, there are a few cases that he did for pediatric patients especially. And another one will be orthopedic procedure, partial neurectomy. Partial neurectomy is something new to me, something I learned in UM during my training. So what we do basically for patients who respond well to our nerve block or our motor point block, these are good candidates for partial neurectomy. So basically they just trace the nerve, and sama principle macam dorsal rhizotomy. You cut a little bit, not all nerve that innervated certain muscle. So the amount of firing from that muscle will be less. So basically, this is just a summary of everything that I said. Sebenarnya ini lagi senang nak baca. So we have therapeutic modalities, we have oral medications, but yeah, we have Botox, we have phenol, yang memang reserved for focal area of spasticity. We have orthopedic procedure as well as intrathecal baclofen with advantage and disadvantage of both lah. Okay. So this is the one that I want to share, the patients in our ward. Right? I just call her May. I just call her May. She is a 34 years old female, morbidly obese, 150 kilos. So the diagnosis is non-traumatic spinal cord injury. Her classification is T9 AISC. So T9 AISC ini meaning dia punya last normal sensory level is at level of T9. AISC is where you know she got intact bowel and bladder sensations. She got power over the lower limb, but the power is not good. D and C, D is a better power. C power tak kuat sangat. So it is secondary to multi-level spinal degenerative changes. And she underwent surgical compression in December 2022 and still currently undergoing active rehab in our ward. So our aim for her initially is basically to improve her bed mobility, including transfer, because she could not be confined to bed all the time. Okay, probably we want to achieve single person transfer with hoist assistance, because the main caretaker, the carer is the mother. The mother pun tak ada muda sangat kan. And then the second one is what we would want to achieve a gradual, consistent weight reduction. But the current hurdle is this patient has a very consistent, very painful lower limb muscle spasm. It is confined to the area of dia punya anterior medial thigh macam tu. It is worsened by movement, changes in posture, as well as limb manipulation. And it evolving, we are not sure why. So our main problem with this patient is kita nak gerakkan dia. Kita nak dia burn more calories. Tapi every time we subject her to exercise or therapy, she will develop spasm. Very painful. So she just end up in the bed. We try to cut her dietary intake. We try to cut her calorie intake. We want to put her in calorie deficit. But we are not able to do that like religiously, because satu, dia pun ada pressure injury. You don't want her to be malnourished, nanti luka tak sembuh pula. And she herself is not compliant to diet restriction lah. Memang carer akan selalu makanan luar, dia akan makan senyap-senyap. So the weight has been static like that. And for all you know, sebenarnya all these spinal cord injury patient, they have alteration in their endocrine punya endocrine punya properties. They have low basal metabolic rate compared to us because they cannot activate more muscles. And actually even kiraan dietary punya keperluan tu is actually lower, tak sama compared to our able-bodied population. So what we do is we try to go step by step. We try to optimize the earlier one, the physical intervention, all this non-pharmacological intervention. We try to optimize that. Our therapists buat all this manual manipulation, massage, stance, all that is available. We try to bagi. Still spasm. So we optimize the medication. Everything is already full dose, backloaded full dose, clonazepam full dose, gabapentin full dose, tak tahan gabapentin tukar pula kepada pregabalin, and analgesic full dose, everything dah full dose. But dua problem jadi. Satu, sakit tak hilang sangat. Satu lagi patient mengantuk because of the side effect of all this medication. So ngantuk pun sama juga, tak boleh juga buat therapy. So it's very challenging. We have to find balance there. So we try to do local interventions. I try to do dry needling for her. It improved, but only for a brief period of time. Dr. Dayani pun buat dry needling for her. It improved, only for a period of time. Dr. Haris buat Botox for her. It improved, but I think it just lasts for 2 or 3 weeks. So banyak masalah. We try to look into the bladder just to rule out UTI. We try to look into the bowel, flush out all the fecal infection inside. Eventually, after we combine everything, kita jumpa seorang massage therapist yang power. Orang Indo, power di massage. So improve lah pula. So which is good lah. Once dia punya symptoms improve, then we could start to mobilize her. We put her in sitting position. This is the patient. We put her in sitting position, try to improve her sitting balance. And eventually, bila spasm dia dah really improve, we try to transfer her to our bed and boleh prop up gradually, because there were times when we attempted this, the spasm was so bad, patient was in pain. So sekarang dia dah boleh tolerate standing lagi lama. Just look at how big is this fella. This is our staff nurse now. Nampak macam besar gila. So after that, we are able to put her on a static bike, and eventually we are able to put her on this wheelchair. So once she's on wheelchair, we hope there will be more energy that could be burned, more calorie that could be burned, because we asked her to propel her own wheelchair. So propel 140, 150 kilos to propel sendiri. So that will burn more energy for her. So hopefully dia akan kurang berat lah. There will be more energy deficit kat situ. Cuma the problem with her, satu benda yang kita tak dapat nak come into conclusion, kenapa spasm ini terus? Whether there's a problem with the spinal cord, sebab kita tak ada a proper MRI for the post. It's not that the surgeon don't want to do, but it is related to our facilities. This lady is so big, she will not fit into our MRI. We talk to our radiologists. Ada tak tempat yang kita boleh outsource? Apparently not in Kelantan. Maybe in KL, maybe boleh, because I've heard some bariatric patient buat MRI in UPN. Those MRI that is reserved for senior, kuda, those MRI. But so far here, we don't have it. So we don't know. So we have been treating her based on her symptoms, so that we could achieve our goals, therapeutic goals. But tak tahu lagi apa actually masalah dengan dia punya spinal cord, whether she develop a syndromyalgia ke apa, we do. But the rehab is still ongoing for her. we hope that she could lose her weight and eventually we can proceed with better investigations and upscale the therapy training. So I think that's it for today. That's the end of my presentation. Thank you very much for your attention.
Muhammad. Seterusnya majlis membuka ruang kepada participants sekiranya ada 9 soalan untuk dilanjutkan.
Tak tahu. Macam mana nak tengok live ni? Saya buta IT sikit. Tak tahu.
Hello. Okay. Assalamualaikum.
Waalaikumsalam.
Terima kasih for very good presentation. Saya Dr. Wan Nasruddin Service. Soalan saya biasa kadang-kadang menjadi Karung honesty. You can improve with massage sometimes.
Yes.
So what actually happened with massage too? I mean, how the mechanism or anything that you get that process. And I was interested that you mentioned very powerful Indonesia that do massage. Because sometimes we do, I mean, because the family also that there are person who have this kind of problems repeatedly, and then you don't know what was wrong going for so many medication, but at the end of the day, it's still the same, still having a problem. But it did improve sometimes with the massage. Any comment?
I actually don't have a concrete answer for this, but saya pun sama, dia macam tak tahu apa masalah dia, kenapa massage boleh improve benda tu. But what I think, definitely benda tu dia bukannya central, definitely peripheral. From my experience, when you are chronically in spasm state, right, you will develop those thought bands and everything, and this will become a vicious cycle. It can create another thought band, catch others, the muscle adjacent muscles and all. And we all know that muscle, you have a fascia. So muscle is individual groups, fascia tu dia macam cover lagi banyak. So muscle here contract does not mean dia kacau muscle lain because of their myofascial connection. It's a kinetic chain. So sometimes when I do dry needling, I release the thought band, I improve the spasm sometimes. Probably what this orang yang pandai massage ni, what they do is, maybe it lies along the same concept, release the thought band ke apa semua, release benda-benda yang ketat sangat tu, then the muscle becoming more relaxed and the symptoms improve. But one thing that we can observe here is benda tu is just short-lived. Dia bukannya something yang will last longer because the pathology is somewhere else. It is just manifestation at the peripheral level. Itu yang kita nampak. But to me, if it works, it works. Because when it works, you can get the patient to do therapy. Saya rasa macam itu lah.
Any other question?
Terima kasih. Very good presentation. Bila kita kata Nyetok Karung di Kelantan, biasa kita tengok di kalangan ahli sukan. Bila dia bermain sukan, lepas itu dia keren.
Keren.
Kalau saya pula, kalau saya bekerja kuat, isi buku, malam tu Nyetok. Kamu punya spasm, the calf muscle, and it will really massage.
Yes.
So
that is due to biochemical changes that we can see here. Whereas this one is neurological. For your patient, it will also be biochemical in your patient.
Possible.
Do you consider hypoparathyroidism?
We do all the workups. Tak jumpa je.
This kind of sportsman.
Okay. All right. Well, thank you very much.
Ada lagi soalan? Kalau ada lagi soalan, kita akan kasih kepada Dr. Sudinasi.
Terima kasih.
Program memakai terima bayar internet kompetensi bagi aplikasi di KPM. Maka bagi sistem seperti so untuk session kita pada hari ini dan untuk makluman insyaAllah pada minggu hadapan sesi CME akan di slot akan diberi kepada jabatan DNP. InsyaAllah kita akan membincangkan berkenaan dengan stroke rehabilitation, house speech therapy for adult and health. So sebahagian lebih ramai yang akan hadir dan untuk mendengar CME berkenaan. Dengan itu, Assalamualaikum warahmatullahi wabarakatuh.